for cardiac reasons. So, what are there are special indications we all are aware, especially for the use of computed tomography scan in the cardiology as well. So right now we have been focusing about the imaging modalities. So what about the important implications? So the first thing is like, why do we try to even use? We all are aware that okay, the gold standard is coronary angiography, but it does have its limitations in the sense it is an invasive test. It takes pretty longer time as well, and yes, it does take a time for preparation, then the recouping time as well, and yes, it can also have its side effect in the sense like there are intra-procedural uh, complications as well which can be happening, and it is important for us to be able to diagnose or detect someone with a coronary artery disease because it is an important cause not only for death but in fact when we try to think for the economical burden on the healthcare as well, it is immense, isn't it? So that is why the MDCT has been used, I would say, due to not just good spatial resolution. With the passage of time, the temporal resolution has also been improving, and the thing is, we just can't only visualize the coronary anatomy, but also the ventricular function, the calcium scoring as well. And this is how it has got into the guidelines as well. So there are various scanners which is available. Can someone recall what are the scanners which is being used, especially for the cardiac CT? So, in like almost in 1980s, one of the first one which came like was ECG based CT scanners. So the main reason for that was, of course, is for cardiac imaging, and in a very very short time, in fact, just in like 100 milliseconds, you could get image. And the thing is, the problem sometimes happens, especially with this scanner, is yeah, the motion artifacts. So as you can see it over here, this is uh, slightly expensive, yes, but so that's the reason it may not be so much widely used. But yeah, especially its physical setup is also pretty cumbersome. So then came the single slice helical CT. So what was happening is this is again also ECG synchronized protocol, and the temporal resolution of course improved quite a lot as well. However, the problem is like we know the heart is big, yes, but it's not so big as well. So that's why it still had the problems of spatial resolution, the temporal resolution, and also the contrast resolution. So that's why single slice helical CT improved into multiple slice. Okay, multiple slice, as I said it. So I remember it was like initially 16 slice CT, then improved to 32, 64, 128, even 256 slice CTs are available. So they tend to have a better spatial resolution, temporal resolution also improves, and yes, we can have a much better imaging of the heart, in fact. So, whenever we are trying to image, I think everyone uses nowadays a smartphone, right? So, one of the important things for us to be able to understand, like how to get a good images, it needs to have a temporal resolution. So, it needs to uh, have a good quality of the image capture. And that's why, whenever we are trying to freeze the beating heart, we should be able to do it in a good way. So only then the image acquisition is going to be better. So even in the heart, there are two phases. One is systole, is the compression phase, and the diastole is the relaxation phase. So for the imaging to be targeted, it is mostly targeted during diastole because this is the quiescent phase, in fact, of the cardiac cycle. And that is why during whenever the recording is being done, ECG must be continuously recorded for synchronization with image acquisition and also reconstruction as well. And one of the other important things, as I had already said, it is spatial resolution. Spatial resolution, because what happens is there may be a lot of structures in a small area. For example, there's a proximal coronary segment. Okay, there may be some plaque which may be there. Then the aorta or those segments can be there as well. So that is why it is very important to have a spatial resolution as well, because as I said it, in a very small area you can get a lot of other stuff as well. So if you will try to look carefully, especially with the passage of time, so many things are happening, isn't it? So for example, whenever at different heart rates, for example, when we are thinking of like a heart rate of around 100 beats per minute, so the diastole keeps decreasing, isn't it? So, and yeah, and the exposure will be needed, for example, for even longer time. So the problem is, so this is one of the other reason as well. We try to, especially for a good cardiac image, we must decrease the heart rate. So what are the desired time intervals? So for example, for a heart rate of around 70 milliseconds, we try to get a temporal resolution for 250 milliseconds. Similarly, if the patient's heart rate is more than 100 beats per minute, 150 milliseconds is pretty good. Similarly, for a 50 milliseconds is good actually for a motion-free imaging, in fact. So that's why the standard of reference for comparing the temporal resolution is fluoroscopy, when the motion is specially frozen during the dynamic image, even for example for some time as well. So we have already have had multiple sessions about the usage of coronary artery, and we are aware that this is the literally the vasa vasorum which tends to supply the heart. Different branches are there: left coronary, right coronary, posterior coronary. In fact, RCA, as we are aware, that it tends to have origin from the right coronary sinus of Valsalva, and it does try to go through the right AV groove, in fact. And then there are several branches for the RCA, like the branch to the sinus node, the AV node as well, and also the PDA. Okay, the right coronary artery, so it gives the posterior descending artery to the AV node, SA node. Yeah. So the conus branch, why is it important is because that is the one which will be supplying the RVOT. But we must keep it in mind, the sinus node artery is a branch from the RCA in majority of the times, yes, 60%. But 40% times it can have its origin from the other one. Okay? Now, how about its anatomy? So that's why, as I said, it is important to go through its anatomy, because you will be coming across these problems whenever, literally right from its origin, then its course as well. How is it going through the different areas and the different segments? So that is also important to comment, and later on I'll show or explain the different findings as well. So, for example, in this, as we can see, especially with the color contrast, the how it is going and giving up the different branches. What about its relationship compared to the other coronary artery branches as well? And then comes the area of distribution. So we are aware RCA is a pretty big branch. It not only supplies the right atrium but also the ventricum, the big part of it, the posterior part of the interventricular septum, and also the whole of the conducting system as well, except the left part of the AV bundle. So the left part of the AV bundle, of course, that will be supplied by the other branches, which we'll speak soon. Left coronary artery, it will take its origin, of course, from the left coronary cusp. And if we look carefully how about its branch, so we can notice it over here. It is there between the RVOT anteriorly and the left atrium posteriorly. So that is why it will immediately, of course, bifurcate into the left anterior descending and the left circumflex artery, in fact, as well. So over here, we will see that they do have different branches. The left coronary artery will bifurcate into the LAD, this into the circumflex artery. And they are obtuse, marginal, the ventricular branches, the atrial rami, or the left coronary arteries as well. So it is always right from the beginning or the origin of the artery go to its terminal branches as well. So it will always give you an idea which artery or which coronary artery is taking its origin from which branch. For example, left main coronary artery over here, we can see it clearly differentiating into the left circumflex, then going to the left anterior descending, and finally we also notice over here is the coronary sinus. So coronary sinus, I hope you understand, this is not an artery but a vein. Anyways, arteries are connected to the veins as well, okay? But that's another thing. Sometimes we can discuss it later. So the important, as I was telling you, that similarly this branch also supplies the left atrium, also the ventricle, okay? The most of the parts of the left ventricle, of course, other than the posterior IV groove, because posterior IV groove is supplied by the PDA. And yeah, it also supplies the anterior part of the IV septum as well, and some small portion of the AV bundle. So here we can clearly see that which part is getting supplied by which branch. Okay, this is a very important imaging memory aid, I would say. So there is a concept, I think, when we were talking about the coronary artery anatomy, what is called as a dominance. So dominance is important for us to be able to understand, like, how are we able to see the majority of the blood flow is through which one. For example, it is determined by the arrangement that which artery reaches the crux and supplies the posterior descending artery. Okay, so that's why RCA is the dominant in 85%. Just think it like that. Right is the dominant, isn't it? Most of the people, right hand is the dominant hand. So this is just a memory aid, I would say. Try to think it like that. And the 8% cases, the circumflex branch of the left coronary artery. And in fact, 7% of the times, it is both the branches. So what happens is temporal resolution, there's a number of factors which tends to influence the temporal resolution. Literally from the gantry rotation time, the acquisition mode, or the type of image reconstruction, or the pitch as well. And when we try to see, for example, the gantry rotation time is actually the time which is required to complete one full rotation. One full rotation is, of course, 360 degrees. So, for example, to go around the patient, how much time does it take? Nowadays, it can be done in like 1/3 of a second. 1/3 or even 1/4 of a second. So it goes so quickly. So in 1 second, at least, it takes like almost 3 to 4 turns around the patient. And yes, faster is the gantry rotation, higher is the temporal resolution as well. And that's why there will be increase in stress on the gantry structure because of the higher G-force. So that's why the strength of the equipment also is very important. The safety issues should be also addressed for that. Then comes the acquisition mode. Acquisition mode, there has to be ECG triggering, okay? And everything is being monitored, because with the ECG you can see whether is it in the systole phase, whether it is in diastole phase. And as I said, it always the protocols are determined, like start the exposure at the peak of the RR intervals, and then the scanner starts at the preset point in the RR interval period, okay? As we can see it over here, this is how the Z position goes with the perspective of the time. So it is important to time them well, because as the patient table has to move by the distance covered by the multiple slices between the scans, a technical delay time, what is called as a scan to cycle time, has to be taken in consideration. And the minimum scan to cycle time between the two consecutive ECG triggered scans depends on the table feed between the two scans and on the acquisition time of one scan. So a usual scan cycle times of the modern multiple slice CT scanners are in the range of like 0.8 to 1.5 seconds. So, one simple question. We are aware that one heartbeat has to be skipped, okay, between every scan of the usual clinical examination at the heart rate between 50 to 9 beats. And so, how much? Okay, I'll just let it go. What are the types of filters which is being applied for the uh, imaging? Can anyone tell me? I'll give you a big hint in the sense like they are based upon the RI intervals. So one is 3 previous RI intervals, the other one is 5 previous RI intervals. So filters are actually used for prospective estimation of position of the following RR waves. So as I said it, so for 3 previous RR waves will be mean filtering. Median filtering is applied for 5 previous RI intervals, okay? So as we can see it over here, with the MDCT, in fact, there's increasing number of detector rows in the z-axis, so larger volume can be covered, and yes, we can further also minimize the motion artifacts. So then what is going to happen is the reduction time is definitely going to be lesser, the temporal resolution can become better as well, and the scan technique normally what we use is like the tube current in milliamps for calcium scoring protocol can be pretty low, and as such each data is obtained during the most optimal ECG signal to reduce the motion artifacts. So sometimes we also do what is called as a retrospective ECG gating. So this is the main choice for data acquisition. Whenever MDCT is being done, this is the main choice. In the sense, the ECG signals are monitored continuously and the data is acquired continuously as well in the helical mode. And both the scan projection data and the ECG signals are recorded well. In fact, the information about the patient's heart cycle is then used during image reconstruction or which is being performed retrospectively. Hence, that's why it is called as the retrospective gating. And the image reconstruction is performed either with data corresponding to the partial scan data or segmented reconstruction. Segmented construction is slightly different. Okay, so what happens is the data from the different parts of the heart cycle is chosen. So the sum of the segments, which tends to equate to the minimal partial scan data, is required for the image reconstruction. But yes, it does have its disadvantages as well, like the radiation dose, and as we already said it, because yeah, some of the partial data can be used also for the final image reconstruction as well. And this scan, as we are aware that this is like a helical scan, so that is why the tissue overlap can be slightly low, and that's the reason which can indicate the excessive tissue overlap as well during the imaging, as we can see it very clearly in this over here. So what about the differences among the retrospective or the prospective? Prospective ECG triggering is usually restricted. Okay, so it is restricted to scanning with the non-overlapping adjacent slices, or on the retrospective ECG gating, it is mostly continuous volume coverage with better spatial resolution. Okay, however, the retrospective ECG gating is less sensitive to the heart rate change. However, the prospective one is the one which is more sensitive. More sensitive means, so for example, yeah, if there's a arrhythmia or Valsalva maneuver and all, it becomes really a big problem. Similarly, for the retrospective ECG gating, faster volume coverage can be done. Similarly, for example, for the prospective ECG triggering, the scan cycle time tends to limit the duration of the scan. Okay. Similarly, the retrospective ECG gating acquisition allows for imaging in a complete cardiac cycle using the same scan dataset. Thus, it tends to provide us the information of the cardiac functions. So when we try to look out for the reconstruction method as well, it tends to have the partial scan. Okay, the partial scan is the most practical solution. Okay, so that's why when we try to have a look here, the partial scan reconstruction can be used for both the prospective triggering and the retrospective gating acquisitions. And the partial scan, the fan beam data set has to cover a projection angle interval as well. And what tends to happen is we have to be able to understand the partial rotation tends to cover nearly 2/3 of the rotation. 2/3 of the rotation means, for example, out of the 360, it will be like 240 degrees. So this is the reason the fastest commercial available gantry, it can go, as I had said it, like even up to 250 milliseconds as well. So in a like 1 second at least, it can be like up to 4 rotations, in fact, at least. So you can imagine this is such a fast device. And half scan is the method of choice, especially for cardiac applications. So this is another beautiful image trying to show the fan beam geometry data and the parallel geometry data. So if we, as I was trying to explain you the mathematical formula which is being used over here. Okay. So we do understand our heart is mostly a 3-dimensional structure. So that is why the reconstruction is always done in the multi-segment. Multi-segment, so what happens is you try to perform a partial scan reconstruction, which is selected from the various sequential heart cycles rather than a single heart cycle. Okay, so yes, it is possible due to the retrospective gating technique and using the regular heart rhythm. And that's why I said it like this. If the patient is having a arrhythmia or the very high heart rate, it can be very difficult. And we are trying to improve the temporal resolution by selecting the projection data from 3 to 4 heart cycles as well. As we can see it over here, in the first heart cycle, this much segment was reconstructed, then the second one this much, then for example in the next one is this much. So that's why 3 to 4 heartbeats are needed, and on the basis of that, the best thing what happens is one can achieve a very high temporal resolution. However, there are some problems as well. Problems like, because you're trying to get the data, for example, from different heartbeats, sometimes a misregistration can also happen, due to which the image spatial resolution will be really bad. So one of the important concepts to be able to especially for the cardiac CT is the synchronization with the ECG and cardiac motion. Why is it important? So as we already said in the prospective or the retrospective data as well, because we are trying to see for each cardiac cycle what is happening. Okay, and that's why all the starting points are determined relative to the R wave of the ECG signal by a phase parameter. And following phase selection strategies can be used. For example, the end diastolic reconstruction or the relative relay and the absolute reverse approach as well. So as I was talking about the relative delay, so in that, a temporal delay is relative to the onset of the previous R wave. Okay. Similarly, the absolute reverse. Absolute reverse is the one in which the fixed times are prior to the onset of the next R wave. Yeah. However, for the absolute delay one, the fixed delay is after the onset of R wave. So as I said it, try to think it in terms of the R wave. What is happening? The relative one will be relative to the onset of previous R wave. Okay. Absolute is going to be prior to the onset of next R wave, and the absolute delay is going to be after the onset of R wave. Okay? Now coming to the pitch. So pitch is actually defined as a ratio of table increment per gantry rotation. Okay? So the values less than 1 implies the overlapping of the X-ray beam and the higher patient dose. And in fact, the cardiac imaging tends to demand low pitch values because higher pitch values tends to result in data gaps, which are detrimental. And the typical pitch values which is used range from 0.2 to 0.4. And that's why at higher pitch there is substantial data gap as well. However, with multiple segment reconstruction, it tends to restrict the pitch error as well. So as I had already said it, the 3D volume gaps as well, it tends to depend upon the various ECG cycles during which the reconstruction is going to be done, and the finally they are constructed together, and this is how you will be able to get the image. So procedure wise, as I had already said it, we are trying to not just see a detection but also analyze the coronary artery disease. We are also interested in depicting the anatomy of the coronary vasculature. And only then we can comment about the contractility of myocardium, the valve morphology and function, and finally also about the viability. And now coming to the patient preparation, what happens is we should be aware about the clinical history of the patient in terms of like what about the symptoms. The patient is having chest pain, dyspnea, or does the patient have any history of allergy, or is there any associated history of asthma or hyperthyroidism, or is there any history of renal diseases or multiple myelomas. Okay, and there has to be an intravenous access or intravenous line as well. Similarly, on the other side, for example, for a good heart rate control is very important. So for which, as I said it, less than 65 beats is the ideal one. So for which ivabradine can be used, or beta blocker can also be used, even sometimes diltiazem or verapamil as well. Then comes the concept of breath holding. Breath holding is sometimes we have to ask and also practice with the patient. Like, can the patient is strong enough to be able to hold the breath at least for 15 to 20 seconds. And for a good ECG gating, it is very important to have a good pad or the ECG sticker to the skin contact. And that is why skin has to be cleaned and good gel should be there. And it needs to be seen even before the patient is being transferred, that has there been a good quality or not. So there are different machines which do try to have slightly different protocols as well. So this is an example for the Siemens somatome definition protocol. As you can see, there are very specific figures. I know some students may not be interested in that, but as I said it, to be able to follow the protocol, especially from that firm, it is very, very important to be able to aware of these values. Okay, so as we could see, so these are the typical images which we can get even during our report. So when or which position was it done, and which are the different segments which were imaged. So among the display of the images, as we can already see, that we are aware that LED artery is best visualized at like almost around 70%, so 2/3 of this cycle. However, the RC is visualized in the early in the diastole, like 40% of the RA interval, and similarly LCX is like in 50%. So not all the coronary arteries are going to be visualized throughout the cycle. So there are different areas in which they will be visualized better, and that's why it is important to be able to time in which segment which is being visualized. So that's why our interactive evaluation with oblique MPR images and sliding the thin slab MIP images can also be proven helpful. and the oblique images are ideal for confirmation of pathological findings in the long and short axis of the vessel. Okay, so that's why and further, some images can enhance the visualization of the coronary artery stenosis in a long axis view. And further, one should be careful, like while one is trying to comment especially about the stenosis in the short axis, because sometimes there can be episodes of false positive readings in absence of calcium. Now coming to the calcium scoring, I'm sure like you all would have come across, oh, this patient is having a very high calcium scoring, this patient is having a very low calcium scoring, okay, and especially which was done on the CT imaging. How would you comment about that? So calcium scoring is actually intended to detect the calcified atherosclerotic plaque burden as a surrogate marker for the coronary atherosclerosis. And it is based on the principle that the obstructive atherosclerotic plaques are calcified, so-called the hard plaques, okay? And the calcium is not present within the wall of a normal coronary artery. So what are the indications? So indications, as I had said it, yeah, if for men more than 45, women more than 55, someone is having a very strong history of family disease, hypercholesterolemia is there, high blood pressure is there, smoking, diabetes, or very high stress lifestyle as well. And so the simple thing, as we have already said, it is, yeah, it is a bit simpler in the sense no special preparations are required. Heart rate should be in the ideal range, so one can give them beta blocker or even ivabradine as well. You don't need to use any contrast, in fact, and 2.5 to 3 millimeters of slight thickness is going to be pretty good. So as we can see it over here, the maximum number of CT, and especially compared to the weighting factor. And on the basis of that, using a special software at the workstation, using various methods, it can be done. So if you may recall that calcium scoring is described in terms of Edgardson score. So score is the multiplication product of volume and the density score. Okay. So the thing is, what does it represent? So if it is going to be 0, then okay, there's no chances of coronary artery disease, or of course eliminates the possibility as well. However, if it is more than 80, the patient will have a sensitivity for prediction of coronary events of 0.85. Similarly, if the patient has more than 160, it will be related to a 20 to 35 fold increased risk for the cardiac event. So it is very important to be able to also understand. So for example, when we are seeing, there will be a lot of those artifacts as well. So sometimes there can be motion artifacts, the misalignment, the blooming artifacts, respiratory artifacts as well, which can happen due to the tachycardia, arrhythmia. Otherwise, if the scanning delay was inappropriate as well. So now coming to the motion artifacts. Motion artifacts, what are they? So as I had said it, in a briefly, like what happens is the imaging of the coronary artery, because they are very small, you need a temporal resolution of 50 milliseconds. Yeah. So that's why the motion artifacts tend to occur at high rates and most often in the mid segment of the RCA. And the RCA tends to have highest velocity movement and greatest positional change in the X-ray and also in the Y plane as well. And it is pretty easy way of reducing or to lower the heart rate as well. And now coming to the misalignment artifacts. So misalignment artifacts, especially if someone is having a very high heart rate, as I said it, or the heart rate variability is going to be there, or if they are irregular or ectopic heartbeats as well. So one has to be really careful. So that is the, if you come across such kind of problems, so what you do is try to reconstruct in the different phases of the cardiac cycle. Any guesses what is blooming artifact? What is blooming artifact? No? No guesses as well? So, the blooming artifact is the one due to the, especially for, as I had said it, for the calcified plaques or the stents which can appear a little bit enlarged. So then can happen is due to the partial volume, the volume averaging effects can obscure the adjacent coronary lumen. So that's why uh, you try to what you try to do is do a non-contrast calcium screening scan before the coronary CT angiography. Okay, so it will be pretty helpful for the blooming artifact. What about the respiratory artifacts? So as you can see it in this image, so there's like a stair step artifact, isn't it? Through the entire data set. So as we can already see what is happening over here. So to avoid this, what would you do? Ask the patient to hold breath for some time. So as I was telling you, the field of cardiac CT as well has been going through rapid transitions. Rapid transitions in the sense from 4 slice to 8 slice to 16 slice, 32 slice, 64 slice, 128 slice. As I said it now, even like I'm aware, like 256 slice CTs, cardiac CTs are also done. So there are different products as well. As well. So some of the most popular ones is from Siemens. Siemens, as I had said it, what happens is uh, you can have excellent images, and the pitch also is like zero point 0.5 to zero point 0.2 itself, and there's a high pitch acquisition mode, and during which only one phase is acquired. Okay, and the images are really good. In fact, there's another models as well from different companies. For example, like this is the one from Philips with a 128 detector row, and with the prospective ECG gated cardiac CT. In fact, you can acquire the whole heart in just two axial acquisitions. So for example, you just need only 3 heartbeats. Can you imagine? So this is so quick, and like 3 heartbeats, you can acquire the whole one. So then comes the Toshiba. Toshiba is a Japanese firm, in fact, and this is the one which has like 320 detector row. Okay, there's a single source, single focal spot, and again, this is really good as well, which takes like very less time again. So as I said, those newer devices are becoming more and more quick, and in fact, as I said it, better resolution with and their team seem to be pretty user friendly as well. User friendly in the sense it doesn't take the contrast which is needed as well for such kind of cases. If it is being used, it will be very less as well. Now, one of the important concept to be able to understand is the cone beam reconstruction. So what happens is the cone beam reconstruction algorithm tends to gain importance, especially for the CT scanners who all are using high number of detectors. Okay, so the reconstruction tends to generate double oblique images, which are stacked like booklets, which are individually adapted and optimally fitted to the spiral path, which is reformatted to a set of overlapping transaxial images. And for single segment reconstructions, one booklet is used for reconstruction and reformation in each cardiac cycle. And the data segments that cover 180 degrees of parallel beam projections are employed for the generation of these booklets. So there are dual source CCTAs as well. So in dual source CCTAs, as I had said it, the temporal resolution will be like nearly half in the multi-slice, or in the dual source, it will be like 1/4 of the gantry rotation. So which is going to be independent of the heart rate. And yes, so you did not bother really about, the heart rate is pretty fast and blah blah. And there's of course there's no need then for the multi-segment reconstruction as well. So definitely it does have good advantage. And here actually the complete data set of 180 of the parallel beam projectors can be regenerated from 290 data sets, of course. So again it becomes 180. So that is one of the big advantages for this. So one of the important things for us, especially to be able to get a good images, a good temporal resolution as well. And as I had already said it, it is quite a lot dependent on the heart rate, and that's why we try to control the heart rate as well whenever we are trying to do the cardiac CT. So the basic mode of operation tends to correspond to the single segment reconstruction. Nevertheless, the multi-segment approach can also be applied to the DSCT, which we said it, to improve the temporal resolution. We should be able to understand there is still a radiation risk even with this imaging as well, although the risks are higher with the MDCT compared to the EBCT in fact. And especially with the calcium scoring, we can expect like 1 to 3 millisieverts. However, for retrospective gated CT angio, we can expect like 8 to 22 millisieverts in fact. And then when we think about, so this is another beautiful chart which tries to show that during the different procedures, how much can be the radiation exposure, especially to the patient. Believe me, there can be several multiple choice questions as well from this for the exams, or even sometimes during the Viva voice as well, especially if one would like to specialize in the cardiac imaging in the future. Okay, now coming to the I think most of the topics we have already covered. Okay, and so these are the different images, how it happens, like in the different cycles, cardiac cycles, for example, in the insystole, how it looks like, in the different in the indiastole, how it looks like. So when we are reaching towards its end, we should be able to understand some of the limitations, in the sense like it's a wonderful diagnostic tool. It helps us in the non-invasive diagnosis, estimation of the calcium scoring, the coronary artery disease, and also comment about the left ventricular ejection fraction. But it does have its limitation. What are its limitations? Can someone summarize it for me? So limitations include, we all should be aware, like radiation risk is of course there, and extensive calcifications, if it is there, it can be making it more difficult. Similarly, if the patient is having a stent, a spatial resolution can be a big problem for that. Similarly, if the heart rate is going very high, so the heart rate is the one which is going to cause problem with the temporal resolution. And if we are thinking of the septal branches, especially if there's very small branches and all, it can further cause much problems. But I must say as well, science has been moving really, really quickly. Your cell phones are becoming smarter. Similarly, are these devices as well, or these gadgets. Better tools are coming, and in fact, nowadays, in rapid chest pain access clinics as well, its role has become quite a lot immense. It can also be used for triple rule out tests. Triple rule out tests, for example, to evaluate the thoracic aorta, the coronaries, and also the pulmonary artery trees as well. So, as I said, triple rule out test. So, triple rule out will be for the coronaries, pulmonary arteries, and also the thoracic aorta. And we can also see, for example, for the coronary artery opacification gradient as well. So, how is it going, for example, for the myocardial imaging for the function, perfusion, and also the viability. So, to summarize, it's a great tool, and especially whenever we are trying to have uh, a dependability, we try to expect a dependability, especially for detecting the coronary artery disease or the cardiac disease, especially in a non invasive way. Amazing tool, I would say. So, the benefits can be immense, especially if you try to focus on using this device, for example, with minimal cardiac risks, especially exposing or limiting the radiations as well. So it is highly demanding, and if you can use it in a optimal way, it's a great cardiology tool for sure. So, are there any questions?